Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, and I am here today with my non-perforated co-host, Dr. Millicent Rovelo, who has no septal perforation.
I have none.
That's right.
I have no septal perforations to disclose.
That's right, thank you. And I'm excited to talk about septal perforation because we were talking today about it, and I said, oh yeah, just pull up the podcast episode about septal perforation. There wasn't one.
Crickets.
How can we not have one about septal perf? This is something that people definitely want to know about.
Yes, I'd say there's a small population of people who want to know about septal perforation. But that's why we're here. I don't think the average person walking around the street is thinking about septal perforations because they don't know what it is.
They don't even know what it is.
But if you have it, then you want some answers.
Yes. So septal perforation is basically a hole in the septum of the nose, which the septum of the nose is the tissue that's made of mucosa, lining of the nose, and cartilage that goes between your two nasal passages. And it's what people talk about when they have difficulty breathing through their nose. They often have a deviated septum. They say, oh, I heard from my ENT that my septum's deviated, so can you fix that at the same time you do my rhinoplasty?
Right.
So septal perforation is when you get a hole through the septum from the left to the right or right to the left, but there's a hole,
connection.
And you can pass
Floss.
things through there. You could pass a piece of floss. You could pass a cheese sandwich through there if you want to. But it's usually a small hole, but it can be a big hole, and it can range anywhere from something that's a couple of 3-4 millimeters up to something that's a couple of centimeters,
yeah.
Or it can be totally gone. And we'll go over reasons why that happens.
Yeah, I think that it's very important to talk about why it happens and what we do with it, and and whether or not they even need to be fixed.
Well, a lot of people are walking around right this very minute with a septal perforation that they don't even know it.
Oh, I know. I remember right out of training, I had a patient in the ER with like a bad nasal fracture that I took to the OR to reduce. And when I really got in there and took a good look, there was a giant, 1 centimeter hole in their septum. And I was like, oh, what do I do with that? And then I was like, oh, wait, that's clearly been there since forever. It was lined, it was open, it was smooth. It wasn't a traumatic perforation from the nasal fracture. The patient had no idea. They're like, oh, really? So it can be completely asymptomatic, usually when they're larger. When they're larger, they can be really asymptomatic.
Right, and you can have them either congenitally or you had a nasal trauma a long time ago that you had what's called a septal hematoma, blood clot in the mucosa that eroded the mucosa and the cartilage, and now you have a hole. They do happen with surgery, so people who have a septoplasty, there is an incidence of septal perforation that does occur, and that can also be asymptomatic, and they can be symptomatic, which we'll talk about symptoms in a second. And then it can occur from cocaine use, which is really common. So, and cocaine is back right now. It is stronger than ever in Los Angeles anyway. I don't know about, I'm sure it's good in going strong in Miami, but
I'm sure.
So because people are using more cocaine, we got some more septal perforations coming in.
For the same reasons. Really, all of these things are because the blood supply has been shot.
Right.
So whether it's from a trauma, whether it's from previous surgery, whether it's from cocaine, which reduces blood supply, whether it's because you had a septal hematoma, which causes pressure, you lose blood supply, you've lost the blood vessels to that septum, and it dies. A portion of it dies.
Right, and the Afrin abusers are the other people too.
Yeah.
The people who can't breathe because they have a deviated septum or they have valve collapse and they're spraying Afrin into their nose constantly.
Which vasoconstricts, makes the blood vessels smaller,
Kills the
diminishes
septum.
blood supply, septal perforation.
Right, it's a very sensitive area, and so you wind up with a hole in your septum. Now, if it's asymptomatic, you're not going to know about it, and there's nothing to do about it, and nobody cares. It's just like you've got a hole in your septum. Big deal. Yeah. But if it's symptomatic, you'll typically know about it. The most common thing that I see is whistling. They breathe through their nose, and they hear a whistle.
Yeah.
And it's annoying. And they whistle at night when they're trying to go to sleep, and they whistle when they're
while they
talking. It's awful. And so for those who whistle, that's a reason that can bring you in for septal perforation.
Yes.
The other reason that people come in is because of bleeding. The perforation can have turbulent airflow going through it, and so you get drying, cracking, you can get bleeding, all those things, crusting that can cause you to come into your doctor and be like, what is going on in my nose? And you find this hole, And it's it doesn't have to be huge. It can be, in fact, the smaller ones tend to whistle and can be more symptomatic.
Right.
Infections can occur in these perforations too, because the tissue is compromised. Obviously, it happened for a reason, and so the lining around the hole in your septum is sometimes not so awesome, and so that's why you have all these symptomatic issues.
So how do you fix it, doctor?
Well,
If it needs to be fixed.
If it needs to be fixed, there are many ways to approach these. I will tell you, for those of you who are listening going, I have a septal perforation, what should I do about it? They are difficult to fix and keep them fixed. Now, I find it very easy to get them closed from a surgical standpoint, but getting it to stay closed, that's a trick. And when you read the reports in the literature, there's, a lot of like, oh, we were able to close it. I'm like, okay, how was it at 3 years?
Yeah.
Talk to me about a 3-year follow-up. Not a whole lot of people talking about that because the results are not awesome.
And why would that be? What happens? Is it just still a blood supply issue?
It is. You're talking about, so now you're going to take this, tissue that isn't awesome and move it around and try to get it to stay closed.
And it's still not awesome tissue.
And it's not awesome tissue. It has a hole in it that to begin with. And so now you're looking at the edges of it and trying to make it heal together. But I will tell you that in the early parts of my career, my success rate was not great. It was probably 50-50 that they'd be closed at 1 year. At this point, it's higher. I don't want to say what it is yet because I'm still kind of like looking at my techniques and all that, but it's higher and it's better. And so as you move on through your career, I mean, having some 5,000 rhinoplasties behind me at this point, I can get things to work better than I could when I'd only had 1,000 of them behind me. But the way that I do it is I use a very big flap of mucosa, of mucoperichondrium, the lining of the whatever's left of the septal cartilage and mucosa. The lining is the key, and I will make big, large flaps from the floor of the nose up onto the septum, and I will rotate that whole flap into position over to cover the hole, sew it closed, plus or minus some sort of fascia graft on the other side, plus or minus. A lot of times, if the flap is really robust, I don't put anything there. I just leave the Doyle splints in for more time than my patients really want to talk about, but 3 weeks, basically, 2 to 3 weeks. Because it will mucosalize on the other side. Sometimes I don't love it, how it looks over there, and I will put a piece of fascia on that side. I'll take a deep temporalis fascia graft, put it on the opposite side. And that's my basic go-to repair. Very rarely do I use a composite ear cartilage graft or something like that, but I will use that in certain instances when there's a kind of adjacent cartilage that I want to bolster the size of the L strut or something like that, but that's very rare. With that said, that's the go-to, and I'll do flaps based on the superior blood supply, the blood supply up towards the nasal bones. I'll do it based on the inferior blood supply. In rare instances, you need to close a posterior perforation. They're usually not symptomatic in the posterior aspect. It's when they're up front in the nose that you're having problems. And so that's the go-to. Now, if that doesn't work, then you're talking about pericranial flaps, and these are little more. It's a little more surgery, a little bit more involved, where we're making a coronal incision and taking the pericranium, tunneling it down.
The pericranium is the lining of the bones.
The lining of the skull. So,
yeah, your cranium.
you're talking about the
bones of your head.
Noggin, baby. Yeah. And you have to expose it, make a flap, and tunnel it into the nose. And they're usually very vascular. And I've got to say that this technique works. It does close the perforation, but it's a big commitment. It's a big operation. So that perforation better be really symptomatic to go through this to do it. But some people need it, and they're really miserable, and so that's how you fix that with a vascularized flap. I think doing free flaps for giant perforations that's not in my wheelhouse lately. I don't do that. I've done it. It's always problematic. It's really hard. It doesn't work well. So sometimes, You just have to say, look, you're going to have to live with the perforation the way it is, and let's manage it medically. Let's get you to do lavage of the nose, and let's clean it out, and let's, control the mucus, et cetera, so that you can live without being completely miserable.
Right. And so how often are you doing a septal perforation repair in conjunction with a rhinoplasty, or are these independent surgeries that they would do on their own?
I do them in conjunction a lot of times, and a lot of times I say, the problem with doing the perforation in the setting of this rhinoplasty is the closure of your septal perforation is at odds with what I need to do for your rhinoplasty.
Okay.
So we're going to do your rhinoplasty first, or we're going to close your septal perforation first, and then we'll do them together. In most cases, I can do them together. In most. But there are, and I do isolated septal perforation repairs. I had a patient recently that just was miserable with her septal perforation. And by the way, like she could have used a rhinoplasty, but she was like, no, I love my nose. It's fine.
Yeah.
I just need this perf closed. I broke my nose, and like, I think that's when this occurred, or, whatever, but close it up, please. And we closed it, and all good. Like I said, there are no high fives or congratulatory statements until it's a year out, because, these do open. And if they do open, you have to kind of go back to the drawing board, figure out why it happened. And then, if plan A didn't work, don't do plan A again. You have to change the algorithm and go a different direction, because it re-advancing the flap failed already.
Yeah.
You already proved that didn't work. So please don't do that again. It won't happen. Pick a different direction, pick a different, modality of how to get it. Maybe it's a flap from the other side. Maybe it's a little rotation of the old flap with a new flap. Like there's a lot of things that you can do, and you just have to be smart about the diagnostic. And this comes up all the time in plastic surgery. Be smart about the assessment, because if you think you're just going to, cowboy this kind of an operation, you're going to have a failure, and that's not worth your patient's time. And quite honestly, it's not worth your time as a surgeon. So, make sure that you really spend time on it. And as the patient, if you're talking to your surgeon about, just say, what are the odds that this is, going to stay closed? Because I think septal perforations the symptomatic ones are a real problem.
Yeah, because even failure by a couple millimeters can be catastrophic, because it only takes a couple millimeters to have symptoms.
Back at square one, aren't you? Now you got whistling, and you got, because that's annoying. Again, though, little tiny perforations that aren't symptomatic, leave them alone. Big
giant perforations that aren't symptomatic.
Yeah, leave them alone. I find them all the time. I had a guy come in for a rhinoplasty, and I looked in his nose, and it was like those, caverns they show in the Ozarks where you go down and like, okay. And I was like, you don't have any septum in here. And he's like,
huh. How about that?
Do you think it was the cocaine I did in college? I was like,
most likely.
I think you probably snorted, half of Jamaica in here. I don't it's gone, dude. There's nothing in there. So, that's an important thing too, to disclose to your plastic surgeon, because I typically, when I'm doing a rhinoplasty in general, I tell people, look, if your septum's no good, if I want to use your septal cartilage to make grafts for your nose, like if the cartilage isn't good, I'm going to use your ear cartilage. And I tell this to every rhinoplasty patient. They're like, why would my septum be no good? Well, you had an Afrin problem that you just used Afrin like crazy, or a cocaine habit you forgot about. And so it does come up where you get in to do a rhinoplasty and the septum is terrible. It's like it's essentially non-existent, even though the mucosa may be closed.
Right.
So those issues that come up in terms of the septal cartilage are very real. So that kind of points all to the reason that people get septal perforations.
Well, thank God there's people like you to fix them. I'm just going to stay with my little breasts.
Yeah.
Well, my big breasts.
You have some patients with some really big breasts, because that's kind of your thing, is the reduction. So I don't know if little breasts are the right terminology for you. But I think it's important to talk about. Perforation is part of doing rhinoplasty. Mm-hmm. I've gotten septal perforations after doing a standard, straightforward septoplasty, and if you read the consent form, it's a risk of surgery.
Yeah.
It doesn't take much.
You're opening up the septum, you're closing up the mucosa. It's totally possible that it could break down, and it is very much a real complication of just a straightforward rhinoplasty.
Yeah, and it's something that happens, and most of the time they're not symptomatic, but if they are, then, we got to talk about closing it for you so that you don't have those symptoms.
Yep, sounds about right.
I think that's about it on septal perf.
For all those people wandering around asking about septal perforations.
Which is like 3 people.
Here you go. Here's your podcast.
No, if you've got one, I know you are.
Oh, you
are
are.
listening to
You are
this
listening.
podcast for sure. But I do like tackling them. I don't, this isn't like an ad for everybody with a septal perf to fly to Beverly Hills. But if you need to, I'm here for you. And I will work very hard to get them closed. But typically there is, in your city, wherever you are listening to this, there's someone that is interested in this and can get these closed for you
Yes.
with, a good approach. So, definitely don't lose hope, but, do your homework, find somebody that's got game, and they will get it done.
Good.
Well, great. This is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.